Okay, what I'd like to do in this video is to go over Vera's case study. Now, she's a 62-year-old female, and if you look at the symptoms she has listed as chief complaints, she writes, number 1, brain inflammation degeneration is her number 1 chief complaint. Her number 2 chief complaint is severe long-standing constipation, which include flatulence, constant flatulence, mild pain, both sides of the pelvic areas, mucus, especially after coffee enema, pain in the esophagus while swallowing. And then she uses the term flare-up signature attacks, which is just a term she's made up for her symptoms. And she has these flare-up attacks, which are persistent over the years, that includes sudden enormous fatigue, weakness, and burping attacks. And then as we go through her 4th complaint, she talks about EMF hypersensitivity and insomnia with inability to go to sleep, stay asleep, wake up at odd times, unable to go back to sleep, body temperature regulation issues, and then lots of dental issues and lots of symptoms there. Now, if you guys know from how I do things in the bonus videos, when I evaluate a new patient for my office, I have them send me a case study document first, like this, and then I go over it, and then I have a quick contact with them, and a little Zoom meeting, and just have an idea of my impression of what I think is going on to them, and if it's worthwhile coming to see me. Most of the patients I see in my practice, like many of you, are traveling, and we do see a lot of international patients. So I always want to make sure that I can look at a case study and determine if I think they need to come to the office or be somewhere else first. And I can tell you, the minute I read Vera's case study, I'm like, your diagnosis is pretty clear. You have microvascular disease of the brain. And, when you look at her case and look at her workup in over 30 years of healthcare, it's really sad how this wasn't diagnosed. But let me go over some of the key points here. And by the way, one of the things I asked her to do before I got a chance to do a physical exam with her is to get an updated MRI, because she had to do previous MRIs that show some signs of microvascular disease, which were ignored because they typically are, they just say associated with aging. But anytime you have acute onset of symptoms, like acute onset of neurological symptoms, it's either an infection, auto or inflammatory response, like an autoimmune response, demyelination, or it's vascular. And she has indications of both of those things happening to her. Now, let me go through and go over this really quickly. So these flare-up signature attacks is just a sudden onset of symptoms. Burping attacks are just going to be anything that hits that lateral pontine area of the brainstem, where you have the vagal motor nuclei, the glossopharyngeal nuclei, that brachial arch derivatives. So off the basilar artery, there's little small tiny branches, these pontine branches that go into the area. So a sudden mini stroke in that area can cause those symptoms. Changes in voice strength, changes in breathing, these are going to impact pneumotactic centers of that lateral brainstem. Changes in voice strength are going to impact pathways associated with motor function. This is going to be more of the anterior regions of the midbrain brainstem, the cortical bulbar pathways. So right away you're like, okay, these are acute onset types of patterns. Now, when you look at her symptoms and her history of all the people she goes through, she gets the basic greatest hits of functional medicine. You have Lyme's disease, you have this, you have mold disease, you have heavy metals, you have all these things. And even though the diagnosis couldn't be any clearer, everything gets ignored, right? So, yes, someone could have, for example, Lyme disease, and that's going to cause inflammatory responses to the brain. But, why is it happening? Where is it? Why is it acute onset? This doesn't make any sense. But in any case, let's go through a case. So, obviously, we got to figure out why she's having this chronic, long-standing constipation. And then when someone has microvascular disease and they have small little bursts of their small, tiny blood vessels, sometimes they're silent, and then sometimes they express more obviously clinically if they're larger. So you can have someone, for example, have a change in their voice strength or have dysarthria develop, or maybe they all of a sudden they have a little stroke, and then they get some numbness in their face that lasts for a while, and maybe goes away as their injury heals. Maybe they have some permanent impairment. Maybe they have some weakness in their face, and 90% of it comes back, and they have 10% deficit sense. They could have a sudden onset of any kind of motor loss, like a foot drop all of a sudden, or a hand that just can't clench like it used to. Or if it's the motor pathways. It can hit the sensory pathways. And if it's the sensory pathways, they could have like sudden tingling or numbness anywhere in the body. They could have sensations of warm, cold feelings, or vibration or electric-like symptoms that are happening depending on what if the sensory pathways are impacted. So, when you look at this, it's not strange. Like when you go burping attacks is lateral brainstem areas. These are vagomotor responses. They're spontaneous firing, or what they call epileptiform activity of these areas of the brain firing. So that's pretty obvious. So when she has these attacks, these flare-ups, and what she calls signature attacks, and she just uses this term because she thinks it's unique to her. It's not really a disease, but it's just really microvascular disease that's impacting some of these regions of her nervous system. So the burping attacks is basically going to be lateral pontine branches, fatigue, muscle weakness, burping, mental fatigue, brain fog. That's just the inflammatory response that's taking place. Increased head pressure, head stuffiness. Those could be just sensory perceptions. Eye discomfort, we don't really know what that means. And we still have to do a history with her and figure out what all these things mean in more detail, but a lot of it is pretty straightforward. Intensified pain sensitivity all over. So that's the somatosensory cortex being blocked close to threshold. So when there's injury, neurons can spontaneously fire. When there's inflammation of the brain, the mitochondria loses the ability to have mitochondrial ATP production. So there's a mitochondrial uncoupling where the system becomes inefficient. And then when the mitochondria from a neuroinflammatory response are uncoupled, there's not enough ATP to support the sodium-potassium pump. So sodium goes into the neurons, but it can't be pushed out. So neurons get close to the threshold, and they can even spontaneously fire because of those electrochemical gradients that's induced by the neuroinflammatory response. So if she has spontaneous firing of her somatosensory cortex, or pathways associated with sensory perception, she can feel tingling and numbness all over. She can get a buzzing feeling, electric pole feeling, whirlpool feeling. These are neurological. These aren't like weird things. So when people don't understand neurology or the brain, typically people like Vera walk in and just get diagnosed as being weird and strange, and they're not. They're just not being diagnosed properly. Hypersensitivity exposure. So with any inflammatory response injury to the brain, or when neurons get close to threshold, because their mitochondria are uncoupling and they can't maintain a healthy resting membrane potential close to threshold, they become extremely sensitive to things like EMFs. It's very common. As a matter of fact, whenever you see EMF hypersensitivity, look for brain injury, look for neuroinflammation, look for something that's impacting the electrochemical gradients of neurons. Exposure to screens like computers mainly cause headaches. That's just neuron fatigue. So blue light has a significant impact on visual pathways that impact the occipital lobe and even activate pineal systems and autonomic centers. And if neurons don't have healthy mitochondrial activity and they fatigue, that light stimulation can then just fatigue the whole brain, and they can have all types of various sensations. Sand in the eyes. Of course there's no sand in the eyes. These are just autonomic changes, blood flow changes, epileptiform activity changes, brain fog, hypersensitivity. So this is just things that are fatiguing her. Now, increased mucus is not going to happen from a brain light issue. This could be immune related. So she definitely has some immune related issues, and she probably has a combination of like microvascular injury, small little blood vessel ruptures. Sometimes they're silent, but even though they're silent, they cause debris in the brain because of the injured cells, and then glial cells around it get activated, and then the whole brain gets primed. So now you get all these different areas of the brain where you have priming. And when you look at MRIs, people have microvascular disease, and even some of Vera's past MRIs and her more recent one, she's got she's got what they call, supraventricular white matter hyperintensities all throughout the brain, which means there's little spots all over the brain of injury from blood vessels basically at the end of the branches rupturing, and that's going to cause injury to neurons. Then the surrounding neurons are going, the surrounding microglia are going to get activated. Now you get a brain that's primed. We talk about this in the neuroinflammation course. And once that's primed, it takes very little immune activation to trigger it. So she could have something trigger her immune response. It could be environmental. It could be airborne compounds. It could be dietary proteins. It could be chemical oxidative stress pathways, and then those mechanisms will increase inflammatory cytokines, oxidative stress that'll turn on these glial responses. And here where she has signature attacks, you already know that she's got severe priming in the lateral brainstem area and pathways associated with her neurotaxic centers as well, and probably areas over her parietal lobe. So during the examination, we're going to really want to do a very careful examination of her somatosensory cortex or parietal lobe. So we want to look at things like if she can perceive where her body is in space, if she can perceive pinwheel sensation from left to right, if she can perceive vibration sense, if she can distinguish extinction from one side to the other. We can have her walk with her arms out and just do like a parietal march and see if she sways or shifts because she thinks her body's in a different position. So those are all the things that would let us know that her parietal lobe is involved. Now with her burping attacks for the lateral brainstem, we really want to see if she's got any kind of palate paresis, if her palate's not moving, if there's any issues with swallowing. I think there may be some indication of that in her history, but we want to check. And then just go through and see if we can identify any sources of triggers and inflammation. Now, hormone imbalances, you can see as we go through, she's got every single test she does for hormones show low levels. And this is an issue because with people that do have microvascular disease, hormones are going to be very, very protective for them. So we got to figure out what the story is with that. Insomnia. So she can't get to sleep, she can't stay asleep, she wakes up at odd times, unable to get back to sleep for a long time. So the act of falling asleep, it really requires the cortex, the neocortex, to inhibit the reticular activating system. So she may not be able to do that. Now some of these may be blood sugar related, some of these could be related to, like, if people have increased parietal lobe activity, just too much sensation on their skin at times can wake them up. They could be very sensitive to touch from their partner when they're trying to sleep. They could have overactive auditory pathways where any critical sound, small sound, can wake them up. So this is something to learn more about. So excess mucus production, we're always thinking about something triggering the mucosal immune response. This is the IgA response. Body temperature and excess mucus production. If it's after foods, after dietary consumption, then there's dietary protein. But if it's just happening all the time, then it could be more airborne. So we'll look at that. She definitely has, if you look at her history, she's got some severe immune reactions to mold that constantly show up. So she has positive mold antibodies on several occasions. She has mycotoxin levels that are high, even on recent testing. And she has a history of mold-related issues. So she may have mold allergy developed. She has IgG testing, but not IgE. We may want to do that. We have to have more discussions there. Her body temperature regulation, we got to find out more about. So she's 62. I mean, obviously she's not perimenopausal. She's probably gone through menopause for many years ago. And her feelings like fainting when too hot, unable to get to cool space, this may not be hormone related at all. This just could be microvascular injury of thermoregulation centers. So you can have microvascular injury to different hypothalamic regions and just have abnormal thermoregulation. It has nothing to do with the thyroid, it has nothing to do with the hormones, but it's a consequence of microvascular disease. So that's there. And then she has this long history of just, dental issues, dental flare-ups, and past infections. So this is something we got to figure out where she's at with this, and if she's going to be working with a good dentist or what's going on with that. But that's important. So she goes in here and says, here's a list of symptoms, these signature flare-up attacks, which she's not aware of what they are. These are more likely injuries to the lateral brainstem, and you get reactivation from glial priming. Anytime someone has microvascular disease, you're going to also teach them to look for any new attacks. So any acute onset of new neurological symptoms will be something you want to look for. Okay, fatigue, exhaustion, physical, environmental, especially emotional stress, night sweats, constant fibromyalgia like muscle pain, body tenderness. She definitely doesn't have fibromyalgia when you look at her history. It's just not the pattern. Sensitivity to high and low temperatures, that could be a little thermoregulation issue. Multiple chemosensitivity, she's not really sure what that is. I'm not really sure what that is. Just reading her case review. On the metabolic assessment form, if she doesn't have any symptoms that are significant there, so we'll see what that is. Weak voice is never good. So we want to look at her voice when we do a history on her. So how does she speak? So does she have hypophonia, meaning she just can't produce words? You see that with the basic ganglion direct pathway not working. Does she have like staccato speech where her voice is like blah, 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 like vibrating, like a vibration type sense? Do you see that with cerebellar patterns? It's almost like a dysdiadocho confusion of the voice. Or does she just have dysarthria, where she just has like a rough voice where things aren't smooth, when vocal pronunciation is not smooth? And you'll see that with impacts of things related to the motor pathways. So we really want to figure out what this weak voice is. So our initial survey, as soon as we see her and we start talking to her, we want to really evaluate her voice and see what's happening there. And then she complains of tension, headaches, brain fog, sensitivity, eye floaters. Eye floaters could be hypoxia to the brain. So when you look at eye floaters, it's either, basically the gelatin-like substance in the eye that is getting thick, and if you close your eyes you can kind of see them in the same spot. If they come and go but they're not always the same, then you could basically have hypoxia to the occipital lobe. That can cause some of these floaters, especially if they come and go. Then you're thinking more like a hypoxia event. So we would definitely want to look for any kind of scotomas. We want to look at her visual fields. See if she's lost any visual fields. That'd be important to take a look at. So again, postnasal drip excess mucus, so something's triggering her immune response. That's important. Occasional pain and weakness in the left arm and leg. So left arm and leg weakness is going to be associated with a contralateral brain. So the right motor pathways. So remember, the motor pathways are in the motor strip. They cross at the pyramidal decussation in the lower parts of the brainstem, and then they become ipsilateral for extremities once they get past that brainstem area. So in the spinal cord, they become the anterior horn. So if it's the arm and leg, it's most likely up in the brain, down the insular pathways. But we'll have to see. Okay. And then nighttime numbness in fingers. We got to see if that's just blood flow issues or if she has any kind of neuropathy. Toe fungus on second toes of both feet, so that's poor circulation. So those are the key things we're going to be thinking about as we go into an exam. Then as you read her history, she has a history of like mold issues. She has a history of dental problems and lots of dental work. And then you can see like around 98, so this is when she's in her 30s, she starts to get these so-called signature attacks. And that's a little bit early. So with microvascular disease, you usually see it like mid-40s, 50s, you start to have symptoms. But some people start to have them earlier than other people. And, microvascular disease can be simply caused like by an overweight, diabetic, hypertensive patient. We definitely want to check her blood pressure, see what's going on with her blood pressure. She could have high pressure, hypertensive issues her whole life, and that's what's causing these at an early age. There's also possibility for viral or mold-related triggers that can impact blood vessel health and cause inflammation and destruction of vascular endothelium with some genetic susceptibility. Maybe that's a combination. It's going to be hard to say. There's no signs of her being diabetic or have any patterns of insulin resistance on her blood work when you look at her case review. And then she goes, so I was walking. All of a sudden, I started feeling very weak. Boom, that's acute onset. Could hardly walk. So did not have any strength. And to hoe as we came to the plot. So this is, again, sudden onset, acute pathways impacting the motor system. 1980 severe accident, half a ton of concrete fell on her legs. So smash her legs, obviously have significant injury. We got to see how bad that is. She had to learn how to walk for 7 months because of that. Okay. And then 94, she had, strange symptoms began right away after I arrived. Lost my appetite, felt dizzy, nauseated at times. Boom. And that's basically the vestibular cerebellar pathways. May have had a little bit of a microvascular stroke. I was very dizzy, staggering, walked somewhat wrong boats, felt rocking boat, like on the very rocky boat. So we want to see if, again, is something going on with her vestibular system, her cerebellar system? Does she have any autoimmunity there? Or is it just an expression of a vascular disease? From a lab test, it doesn't indicate that she has any specific cerebellar autoimmune responses. She may have some myelin autoimmune activities. I'll show you that in the lab test in a second. But it could just be blood vessels rupturing off that basilar artery that impact that posterior anterior cerebellar arteries, anterior inferior superior cerebellar arteries. Okay, what do we have here? Swollen hands. This is not vascular. This is like an autoimmune inflammatory response. We gotta look into that. And then once again, any of my famous set of symptoms. Immense weakness, severe bewildering fatigue, accompanied by burping. 5 to 10 minutes apart, a couple of attacks intensified, frequency with time. All of a sudden become very tired, weak. Yeah, so these are just, if it's the same area of the brain that keeps having these same responses, that's probably injury to the brain from microvascular disease or maybe even demyelination, and then reactivation with something immune related that's activating those primal glial cells. So it seems like she's having the same area injured again. It's unlikely that you keep having a mini stroke in the same area causing the same symptoms, but you could have an injury to that area and then reactivate it again with glial priming. So then in 2003, after a stressful event, I lost part of my hearing. So that's going to be auditory pathways again, but you could have microvascular injury to areas of the auditory cortex, auditory association centers that can impact that. I got better after a run of antibiotics and steroids. That's going to dampen the inflammatory response. And then MRI discovered white spots in my brain that nobody could explain, since they were not quite what one has on MS. So this is where you just start to hate healthcare and people in it, because this is a red flag. When you have acute onset of a neurological symptom with a past history like she has, and she just immediately loses her hearing, and they see hyperintensities throughout the brain, it's pretty clear that there's some action injury that's happening. Now, demyelination is possible. The white spots could be more characteristic of microvascular disease. I think you see that on the MRI. But she basically gets ignored because lots of people have white spots on their brain. They call it age-associated white spots, but they're not benign. They are malignant, meaning there is injury to those myelin sheaths. So white spots just hyperintensity, which is injury to the myelin sheath. It gets ignored. Then she has severe reactions to mold. You can see those things. She has different antidepressants. She's got a minor mitral valve prolapse. This is important for us because you have to have healthy amounts of perfusion to get blood flow to the brain. So minor mitral valve prolapse. So we want to listen to her heart, make sure she doesn't have any kind of murmur over mitral valve area, and see how severe it is. Really importantly, we want to look at her perfusion index. Make sure she's got enough ejection fraction and pressure in her blood vessels. Now, microvascular disease can be caused by hypertensive patterns. We have high blood pressure, but also there is a mechanism associated with microvascular disease that's associated with low blood pressure, leukoariosis, in which there isn't enough blood flow and activation of the vascular endothelium from lack of blood pressure or ejection fraction in the heart. So there's not healthy amounts of release of things like vascular endothelial growth factor to help blood vessels stay healthy and branch, and then they can become injured in an inflammatory state. So we really want to take a good look at our heart, our perfusion index during the exam, see what's happening there. After mentioning the word died to my doctor, was sent to a psychiatrist, prescribed Lexapro. She gave me real panic attacks, stopped taking it, signature attacks. Then you go through the list, diagnosed with Lyme, diagnosed with chronic inflammatory respiratory syndrome, and DMPS. You can see here she's tried the DMPS heavy metal treatment clearance. Got immediately worse. She thinks it was just redistribution. It's quite possible. The blood-brain barrier is basically blood vessels. And the tiny blood vessels that work with astroglial can constantly get damaged and injured, and there could be some tendency for permeability of the blood-brain barrier, with no question, with her history. So, again, she's going to walk into healthcare, and if you have anything that's weird neurological, then it's got to be heavy metals. And if you walk into healthcare and this can't be explained, it's neurological, you're going to diagnose with Lyme. So she's gone through that whole event, and then she ends up in the yard. They do an MRI and has a history of all the indications of demyelination or microvascular disease, and gets completely ignored. And then 2015, diagnosed chronic inflammatory respiratory syndrome, water damage building. Go through the whole routine. Doesn't seem to make her feel better, actually makes her worse. And I would say there's no question she's got some mold-related issues. But her symptoms, are a combination of various things. So there's a mold component to it. How impactful it is, we have to see. But it's not just mold at this point. You can just focus on mold and trying to kill mold and trying to have binders to mold. You're not going to fix her microvascular disease. Her brain is injured. Her brain is inflamed. Her brain is constantly degenerating. And, with microvascular disease, you get stepwise deterioration. So over time, the brain really atrophies and degenerates. So we definitely want to do some things to immediately impact her blood vessel health to her brain. Make sure she's not hypertensive. Get her nitric oxide levels as high as we can. Make sure she has physical activity. Make sure we can do things to activate her vascular endothelial growth factor. So lots of possibilities here just from reading her history. And then, dental issues we got to figure out. Tested positive for Morcoons. Again, that's part of the whole chronic inflammatory respiratory issue. So this, she's got some immune sensitivities, immune-related issues, EMF sensitivities. And then, after studying her course on fatigue, so sounds like she took the Crosby Institute fatigue course. Started doing more exercises regularly. That's really important for her. And then as we kind of go through, she has some pretty good theories of what's happening to her. You can kind of read those. And then here's a list doctors had on their list 2013. They didn't understand the comments. So she gets diagnosed with all various types of things. You can kind of read through that yourself. And then you can see all the different diagnoses and opinions that were given to her by all various people. And she's seen everything from conventional physicians. I don't know how many conventional physicians we have. 1, 2, 3, 4, 5, 6, 7, 8, 9, a lot. A dozen. To NDs, to DCs, to dentists. Okay. What's improved your health? This is really important. Coffee enema. So coffee enema is going to help get autonomic system changes. It's going to help with blood flow activity throughout the whole body, including the brain. So coffee enemas are going to activate cholinergic receptors. Cholinergic receptors are going to activate that acetylcholine pathway. And as it activates her intestinal motility, also impact blood flow throughout her tissues, including the brain. So it's not uncommon to have many people that have poor blood flow dynamics to the brain do coffee enemas and notice the response there. So FODMAP diets seem to help. So she's got chronic constipation, maybe her gastrointestinal motility is off. She has a FODMAP test in her case review file that shows levels elevate. I'll show you that in a second. Then she takes some digestive enzymes, seems to help her. Enzyme X-Pro is just hydrochloric acid, pancreatic enzymes, and different substances, lipases and proteases and so forth. Cbiotica is just strains of probiotics that people with SIBO can take. Neuroflam are just flavonoids that can be dampened the glial system. And then she has daily walks in the forest that include loud singing and stretching, bouncing exercises. It's really important for us to find out what our exercise activity is. And with someone who's got any injury to their blood vessel system, we got to make sure she has high intensity. So just walking may not be enough for her. Stretching and balancing are great, especially if she's got cerebellar dysfunction, because they activate those pathways. It can be rehabilitative, but we want to see how intense it is. Loud singing is good. It activates the vagal response. Things that cause reaction, so she can't handle the sulfur, seems like. She had a severe reaction to any kind of metal chelation detox pathways there. Reaction to ozone, different drugs. And you can see, when you see a whole list of different nutraceuticals and supplements the person reacts to, you just know their immune system is extremely sensitive. And you got to be very careful using a lot of supplements. When you see someone who's got a lot of reaction to supplements, you're always kind of best to see what they can tolerate and have them kind of stick to what those things are. Then she goes through all the different prescriptions. They put metal rods in her legs. Okay. And then she does a really fantastic job on her case review, explaining every single lab test she has had, what the findings of it were, in a timeline fashion. Now here we are again, October. They see non-specific flare hyperintensities in the subcortical deep and white matter of the cerebral hemisphere bilaterally. So those are basically injuries to the brain throughout the brain. Most of the frontal lobe lesions were seen in the comparison study. The overall pattern is suggestive of small vessel ischemic change. There's your microvascular disease. A few of these lesions are pericallosal. The overall pattern is not suggestive of demyelinating process. So the radiologist here believes that it's more small vessel and not so much demyelination. The first radiologist showed demyelination, and I got to tell you, at this point in my career, I'm so disappointed by neuroradiologists and the terrible reports they write and how simplified they are, and it doesn't really help us. And if you have a good relationship with your local neuroradiologist, you can say, listen, I really want as much detail as you can. Please be very thorough. Explain to me where the lesions are. And then with some people, it's just very general. And with most people, they're very general. And over the past 10 years, I just see reports getting worse and worse. So I'm sure you guys have seen the same thing. Anyways, let's go through all these different tests. You'll see she's got a lot of these antibody tests. These antibody tests, IgG, just mean past exposure. This is a serious waste of a lot of money that's being done here. Probably causing her a lot of confusion. Okay. Let's get... Alright, let's go through. So you can read through the summaries. Neuroquant was done. And the neuroquant is just a qualitative MRI. Small foci of T2 prolongation, subcortical deep white matter area of both cerebral hemispheres, relative sparing immediate for white area. Differential diagnosis, small vessel disease, neurotoxic insult, demyelinating disease. It's a different radiologist report there. Okay. So you can see some genetic sensitivities to gluten on some of our testing as a summary. Okay. Let's go through the actual lab test itself. Let's go over the questionnaire forms first. So here we can see with the brain health nutrition assessment form, section 1 is just symptoms of blood flow and circulation. So we can see some problems here with blood flow and circulation. So it's going to be really important for us to really see if she has any issues with peripheral arterial disease. So once you start to see vascular disease problems in the brain in an MRI from their history, you want to really look at, first of all, circulation and blood flow throughout her body. That's going to be an expression or a clinical window of the vascular endothelium. Remember, the vascular endothelium is an endocrine gland. And it releases growth factors and nitric oxide, which can be neuroprotective. So is she getting those areas of her system injured? We got to really carefully look at her blood pressure, her perfusion index. Want to really look into her eyes very carefully, see if she sees signs of any kind of microvascular disease, the health of her vascular system in her eyes. We definitely want to do a ankle brachial index. See if she has peripheral arterial disease. We definitely want to do things like a Doppler and check for venous insufficiency. So is her blood vessel vascular system healthy or not? Because this just could be a case where it's all about the vascular system. Even though the brain's in trouble, she could have vascular insults all throughout her body. And then the other sections here, you can see some individual symptoms here and there, but no significant category that is really popping up with lots of different 3s and 2s. And these are just symptoms she has with her typical chief complaints. Then if you look at the brain region localization form, I just highlighted symptoms of 4, which 4 means almost all the time. So mental fatigue all the time, difficulty with math, numbers, and skills. And if you look at the brain region localization form, L just means left, R means right. So this is the left, prefrontal areas of the brain. Reduced muscle endurance in arm and legs. This could be to microvascular injury to the motor regions. Hypersensitivity to touch and pain. So this is not going to give us a clue like what areas of the exam we really want to pay a lot of attention to. The prefrontal cortex or orbital cortex, we're not going to have any physical examination findings of this. However, we definitely want to look at her brain fatigue, her brain endurance, her motivation, her ability to get things done. Those things in her history can be really important for us to assess what's happening here. Reduced muscle endurance in arm or leg. We definitely want to check muscle tone. See if she's any kind of spasticity, any kind of hypotonia, any kind of weakness. That'll give us clues if these motor areas are injured. Maybe on one side, maybe on both sides. This is all parietal lobe symptoms. So we're going to check her sensory and perception pathways. And then, surprisingly, she doesn't have a lot of cerebellar symptoms, but she has past histories of dizziness. And typically swallowing supplements or large bites of food, and then speech problems. We're really worried about that. Those brainstem regions being injured, and they're right next to the vagal pathways, which cause digestive complaints. So her chronic gut issues may really just be injury to the areas of the lateral brainstem involved with parasympathetic or that parabrachial arches of the brainstem that impact parasympathetic activity. So we'll have to see. Easily startled, difficult sleeping. Now these are called epileptiform activities. These are where you have neurons spontaneously firing. That happens with injury, neurons close to threshold. So she has them like in her motor system. She has it in the autonomic system. There's no signs of seizures with these yet, but she has spontaneous activity. Then when I look at her gut symptoms, it's mostly constipation. High dry small stool, constipation, some sensitivities to chemicals. Seems like for sure it's mold. She has reactions to mold. Difficult bowel movements, burping, bloating. So this is her intestinal motility pathway. This could all just be for microvascular injury to the lateral brainstem centers. Again, motility, constipation. And then sleep. Now these are typically adrenal symptoms, but for her it's probably not adrenal. And then she's got a lot of electrolyte imbalance symptoms, but these could be not really electrolytes. This could be injuries to those motility autonomic pathways in the brainstem that are causing them. And they're tired, sluggish, feel cold hand, feet all over. It could be thyroid. If you look at her lab test, none of her thyroid markers are ever abnormal. So again, a lot of these symptoms that we associate with these sections, like thyroid or electrolytes or adrenals, may all just be symptoms that are really coming from different injuries of brain to different autonomic centers. Okay, and then as we just go through, then we see her labs. Some of these are highlighted by other people. You can see she's got these high antibodies, IgG. Most of you, if you haven't checked viral antibodies for IgG, whatever, you're going to show up with a lot of them. This means you have immunity developed towards them. Whenever you see high antibodies to any kind of virus, for example, like Coxsackie virus, you have to then look at the total white blood cell count and actual lymphocytes and neutrophils. But if there's actual viral response, not IgG, IgG is just antibody. If you suspect there's a viral response, you're probably going to see a better inspection of viral response clinically with an IgM for that pathogen. And then you're going to see like lymphocytes high, neutrophils low. During viral response, lymphocytes go up. If you do a T and B cell profile, you're going to see natural killer cells involved. You're going to see T helper cells up, B cells down, and that's how you actually know that there is some viral activity that is actively causing an immune response. IgG by itself, without those markers, is basically taking money and burning it. Okay, and then some heavy metal tests. Here you can see they measure cytokines. TGF beta 1's up. So that's a regulatory cytokine that's going to help combat the immune response. Something you want to see high with people that have inflammation. And these are the SNPs. So COMT is important, meaning she's going to have a hard time methylating and getting rid of epinephrine, norepinephrine, estrogens. She's got some glutathione conjugation, SNPs. And you got to take these for what they're worth. The COMT is definitely clinically relevant, and it has a significant impact on symptoms. Like GSTP1 doesn't really. SOD1, SO2, these don't. So why do labs do them? Because they can cluster these together without it being very expensive and just run a profile and get them. Out of all these, the most important one is the COMT. COMT is clearly has clinical relevance as a SNP, especially if it's homozygous like hers. So there's going to be, if she does go on hormone replacement therapy, especially estrogens, she's going to really need to go like very low dose, because usually people that have bilateral CM2 SNPs have a hard time processing steroid hormones, especially things like testosterone and estrogen. Here we can see, like, listen, see this at this date. This is 2014. Her white blood cells were low, 3.4 to 10.8, it's on the low end. But you see this pattern here, the lymphocytes are high, neutrophils are low. And if I saw this pattern with an antibody to a virus that's IgM, not G, then I would think that could be a viral response there. So here, like with this pattern here, with her lymphocytes high, lymphocytes, so these are percentages, by the way, when you look at the white blood cell differential. So if you add up like the neutrophils, lymphocytes, monocytes, eosinophils, and basophils, they all add up to 100, right? Because they're percentages. So when one type of white blood cell goes up, like lymphocytes, which are there to fight viruses, the neutrophils usually go down. So when you see this lymphocyte shift, and you start to see patterns that look like, this is like a reactivation pattern of Epstein-Barr. So in 2014, it looks like she had a reactivation, a flare-up of her Epstein-Barr. So this makes me think there is a viral component to a lot of her symptoms. Her immune system is not the best. And these viral responses can trigger autoimmunity. They can even damage blood vessels. They can maybe turn on the genes with her disease in general. So we have to look at that, okay? And then if we look through the rest of the report, they did a systemic autoimmune screen here in 2014, probably because of her joint pain and swelling. They couldn't find anything there. These are just random tests, nothing that's too critical there. She's showing these antibodies to mold back in 2014. She's getting exposure to mold and she's reacting against it. And here's her neuroquant. Basically throughout her neuroquant test, just to make it simplified, she's got some areas of smaller volume in different regions of the brain. But once again, with this, neuroquant test, they're seeing patterns of demyelinating disease or vascular disease, small vessel disease, which again gets ignored by whoever ran the test. And then this is a real-time lab. They're looking at urinary mycotoxins. They can't find anything present. Nothing's totally elevated there. And then with the Great Plains urinary mycotoxin test that was done, this was done January 2019. This was done at the same time. You can see they're finding elevated levels. Their gliotoxin here is not found, but gliotoxin here is off the charts. Is one lab more sensitive to the other? You don't know. Sometimes you see the other lab having a positive response, It's the problem with lab testing, they're not always 100%, but we definitely see elevated levels of these different mycotoxins, and we have IgG antibodies in the past and a family history of mold, so those are issues. Here's an MRI 2019, small vessel ischemic disease, again ignored. This is her Dutch test. Basically her hormones are low. whenever you look at any of her hormone profiles, however they're done, you just see everything that's low. She's got low hormones all throughout her body. It could make an impact on her vascular dysfunction in her brain. Urinary neurotransmitter test here, all useless. They're not accurate. They don't reflect anything happening in the brain. Okay, and then we can get to, like, here's her SIBO test. Now, her SIBO test, if you see, right at around 90 minutes, her 120 to 150, her levels of hydrogen are elevated. That's one of the criteria. So even though she did her overall hydrogen methane within normal, or actually overall hydrogen here is within normal levels, they say her methane here, peak levels are a little bit high. Right, they should be less than 10, they're 10. The biggest thing is you see this hydrogen level after 90 minutes elevate like that. So this should be considered a positive test to suggest SIBO. So she's got some SIBO patterns here. So this is recent 2021. Now she has no intestinal motility. She has no gastric function. When you look at her history, it's very possible with her symptoms of burping that lateral brain stem area. So the lateral brainstem area has, I keep saying this, brachial arch derivatives. Brachial arch derivatives are the parasympathetic nuclei branches of 5, 7, 9, 10. And once you injure parts of that, you can have significant impacts on intestinal motility. So we got to really see what's happening there. Okay. This is ZRT urinary neurotransmitter test. Totally useless. No reflections happening in the brain. I just get frustrated. Here we see her homocysteine levels a little bit high. So this is 2021. Probably want to get an updated marker. You know, anyone's got vascular disease, you don't want this homocysteine level like this. Now she has a COMT SNP, so she doesn't methylate very well. But, you know, the lab range, you know, is right on the border. Some labs have it high as 15. They're saying less than 10. She's at 10.1. So this is a marker that's really critical for us for vascular disease and injury. Homocysteine is very destructive to the blood vessels. So we want to get an update of this. CRP seems okay there. If you look at her glucose levels, her kidney function, liver function, everything's fine. This MCHC, you know, 0.2 levels below the reference range. That's fine. Her white blood cells are nice and healthy. No signs of clotting. 3.9 fibrinogen levels within normal levels. They can be. They're a little bit more than average. They're in the normal range, but on the higher end. So something to keep an eye on. Another screen for ANA, systemic autoimmunity, negative. And then 2021, she gets a good vascular workup. She goes to these Cleveland Heart Lab. They do oxidized LDL, myeloperoxidase. These were normal. These are all good things to see. And then as we go through some of the cardiovascular markers down the road, they also seem pretty good too. She's going to have some dysbiosis patterns if she has no gastrointestinal motility. This whole dysbiotic growth, you're not going to fix that with the probiotic. Until she has normal motility, you're not going to really see these patterns change. And then zonulin, she's got signs of intestinal permeability here, which is no surprise. And then she's got some chemical reactivity to plastics, tetrachloroethylene, so laundry chemicals, and mercury. Now, this explains a lot too, because you saw with her history, she totally fell apart with chelating substances. Now, chelating substances are going to bind to chemicals and push them from tissue into the blood. And if you have mercury pushed into the circulation into blood by cleaving to a binder, you can have antibodies created. So you always got to be very careful with any kind of chelation therapy when there's immune reactivity to chemicals. So this is mercury bound to albumin, which is what the test is, IgM. So a very acute response to heavy metal binding complexes. So this is not something you chelate. This is something you fix the gut barrier, fix the blood-brain barrier. But this may be a key indication of why she's having reactions to chelating substances. And then here they just the SARC's viral pattern, nothing significant. HHV6 past exposure. She doesn't get to see if she's any skin outbreaks anywhere throughout her body. Now, the interesting thing with this panel is when she did this in 10/2021, her IgG levels were very low, 769. The range, well, I should say on the low end. The range is 751 to 1560, so she was right on the low end. And the immunoglobulin A is on the low end at 126, and immunoglobulin M was much better, but still lower. And that could explain why we may have some false negatives. You can see like some of these antibodies have negative signs. They're very low, 0.42, 0.43, 0.46. So we may be seeing some potential false negatives with this timing when she had the test done. And then when you look at her food sensitivity during the same time, you see some reactions to kidney beans, Brazilian nuts, peanuts. So it's possible she may have some early reactions to lectins or peanuts, but she doesn't have any of the specific lectin reactions like lentil lectin, soybean agglutinin, bean agglutinin. Those are your bigger marker for lectins. So I don't know, we gotta figure out what her response is to her food. I'm not too worried about her food sensitivity pattern right now. And then 2021, lipoprotein A looks good. They go through hemoglobin A1C looks good. No kidney problems. Blood sugar's fine. LPPLA2 activity is a little bit elevated. We don't want to see that. And then as you look at our lipid profile, LDL particle size, a little bit elevated, moderate elevation. Lipoprotein B, kind of borderline. ApoE2 carrier, oxidized LDL, fine. So this is our lipid particles and protein sites. If you look at these, there's nothing that's like dramatically abnormal here. I mean, LDL is a little bit high, but it's not oxidized. Lipoparticle sizes are, the LDL is elevated when you look at particle size, and then if you look at large versus small, like your LDL size, small LDLs, which are the ones you're most concerned with, they're not elevated. So she doesn't have she doesn't have a really significant red flag marker pattern there. And then here we look at her EF, essential fatty acid pathway. Everything's high, so her omega-6 to omega-3 ratio is a little bit low. But if you take lots of essential fatty acids, these will be high. With her, it's not a bad idea for them to be high. When we say high, you gotta remember, what does high mean? How did Quest come up with high, low, normal? The populations, people taking it, not taking it. They kind of give you some ideas, but usually when you have people taking supplemental oils, you want to see what's going on. Now this one through Quest is not a very good one because you don't see the different indexes and ratios and other things that are more important. And they like EPA arachidonic acid ratio. I'd really like to see more of a breakdown there. Like her arachidonic acid levels are fine. I don't know, nothing too significant there. Okay, Crypto pylori. This is another greatest hits. Functional medicine levels are fine. Cortisol levels a little bit low in the morning, low throughout the night. But her salivary cortisol rhythm is pretty. It's still there. She has a rhythm. It's just she goes up, comes down. It's not too bad. It's not ideal, but it's not too bad. There's another report of hormones. Okay. Let's see what else is relevant here. Some toxic compounds. A little bit of these pesticide chemicals. You wouldn't look at these pesticide chemicals and go, okay, that's why she has all her symptoms. That's why she has microvascular disease. And let's just focus on that. We really got to get her blood vessel health immediately better. So we really want to jump on things that impact her blood vessel health pathways, like homocysteine, like blood pressure, like vascular endothelium function. Like these high antibodies mean nothing. IgG by themselves. These high antibodies were found to be elevated with abnormal lymphocyte shifts. Then we were talking about potentially something happening. Let's see if they did those. They didn't do any of those. Okay. Again, IgG. You know what's funny is because conventional medicine runs these to see if you have immunity to it. What happens in like people that don't understand how these tests work, they'll run these and go, oh, you have these pathogens. And that's not what they're interpreted as correctly. Literally, you're just seeing hundreds and hundreds of dollars being burnt up by whoever ordered this panel. And then probably being confused like she's got these viral pathogens there. What she really has is this immunity there. You really need to see NK cells, T cells, lymphocytes elevated with active infections, and you need IgM. For example, IgG, influenza virus IgG, doesn't mean anything. Past exposure, okay. If the IgM was high and the total lymphocytes were high and natural killer cells were high, IgM B cell count was high, then you're going, okay, this is an active infection. But these are not that. Now here is a totally different test. This is the mold response here, mold profile. So even with her recent blood test, let's look at the date. Why don't I just write it on every page? Here, 2022. This is recent, so this is like 3 months ago. So even 3 months ago, we're seeing immune reactions to mold species. So she's getting exposed to mold and she's reacting against it. So we want to see if she has IgE, allergy responses to them. She's developed a permanent long-term sensitivity. Okay, now see at this time, when they ran this panel, they did run basic lymphocyte panel. See her white blood cells are totally fine. See her lymphocytes are even on the lower end of the range. This is not an active infection happening. And these Epstein-Barr viral patterns interpreted as past exposure. Okay, and then more Dutch testing. Everything's low, so we've got to have the hormone talk. Okay, so those are the main things. You can obviously get a chance to go through those yourself and get an impression of what's happening with her. This is Vibrant. So these are microarray analysis. They're not as sensitive or as accurate as ELISA, but even with these tests, they're not totally useless. They still give you some information. So she has like myelin antibodies here. So that's an indication of neurological autoimmune reactivity there. Aquaporin 4, get neurological autoimmune reactivity. So she may have some demyelination happening as well as some small vessel disease of the brain. A little bit of overlap. Those are the main labs. And then she goes to Infecto Lab, and then they say mycoplasma with interferon means indicates borderline active T lymphocytes. No, it doesn't. Interferon gamma goes up with any kind of immune inflammatory response. So I don't know what they're thinking. Cytomegalovirus plus interferon gamma active T lymphocytes. That doesn't mean that they have cytomegalovirus reactions. I don't know how labs just get to do stuff like this. And then this is another lab, long COVID hauler panel, just measuring cytokines. There's no specificity for any of these cytokines for long COVID, so I don't know, is it a trendy panel? Anyway, she shows some inflammatory cytokines, according to them, a little bit high, IL-10. CSD40L, just an inflammatory cytokine. VEGF, vascular endothelial growth factor, that's happening with this blood vessel inflammation, assuming that's accurate. And this is her most recent MRI, just done actually this month. And what they see with the recent MRI is basically white matter disease, hyperintensities all throughout the brain, and they're saying they're not seeing significant white matter changes from the past MRI. It's not progressed very much, which is a good sign. But their impressions are potential potential white matter, non-specific white matter or demyelination, and they also go possibly chronic microangiopathy, which is small vessel disease, microvascular disease. So she's got, 3 MRIs at least that show the same thing, and no one's ever told her. And even if someone has told her, they don't know what to do. She also did an MRA. MRA is MRA angiography to see if there's any kind of abnormal blood vessel vascular issues happening to different regions, if there's any occlusion of blood vessels, any anatomical changes, if her blood vessels are patent, everything looks fine there. And then she does an MR angiogram of the neck to make sure that her blood flow of her carotid arteries is okay and her vertebral arteries are okay, and they're fine. So she doesn't have any occlusion issues with her blood vessels. She just has some patterns of demyelination, white hyperintensities, and blood vessel patterns. Okay, so that's Vera's case. So we talked about what kind of things you want to look for in the exam. If you get a chance, really go through the case yourself, look at the lab tests, and we'll have to see how our history and exam looks like, and then we got to figure out a strategy. As you can see, there's a lot to digest here, and this is a very good example of a patient that has a very clear diagnosis but gets ignored. And the reason it gets ignored is because there's a percentage of the population that have microvascular disease that have no symptoms, so people just ignore it. Traditional physicians, for sure ER docs, neurologists, they tend to ignore it. But there are very clear known populations of people that have microvascular disease and a stepwise deterioration, and it's part of the diff-die, which was never appropriately given to her. So this looks like we have some demyelination, some areas of brain injury. It looks like we have microglial activation throughout her brain. Her gut symptoms may be associated with some of these microvascular injuries to her brain stem. What she calls her signature attacks, or probably glial priming in areas where she has vascular injury. That's the main summary for me as I went through the case. I hope that was helpful. Thank you.